Before we start this podcast, we'd just like to do a quick shout out to all of those supporters who've donated more than $100, including...
Did you say Bobcast?
Bobcast.
Podcast, including Joanne Lynn, Sharon Bragman, James Tulsky, and Yana Scharf, Kelly Straight, Michael Borodovsky, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, the John A. Hartford Foundation, Lloyd Woolstat, and Harry Hahn.
Thank you, and on to the show. This podcast is CME eligible. To learn more about CME, Alex, what do they do?
They can either go to the CME tab associated with this episode, or they can go to jerrypal.org/CME.
And on to the show. Welcome to the Jerry Pal Podcast. This is Eric Woodare.
This is Alex Smith.
And Alex, who do we have talking with us today?
We are delighted to welcome back Stephanie Rogers, who's a geriatrician, medical director of UCSF's Age-Friendly Health Systems. And Stephanie's standing right here with their fiddle at the ready. Stephanie, welcome back to Jerry Pal.
Thank you. So happy to be here.
Stephanie, you're an Instagram star too.
Yeah, I guess I am.
What is your Instagram handle for our listeners?
It's Age Well with Dr. Steph.
Millions of views per post, right?
Yes.
Yeah, check it out.
Check it out. We're also delighted to welcome Julia Adler-Milstein, who's a national leader in health information technology policy and research and chief of the Division of Clinical Informatics and Digital Transformation at UCSF. Julia, welcome back to the Jerry Pal Podcast.
Thanks so much.
And Julia's joining us from Minneapolis, which is about to get a big snowstorm. So we hope that our internet holds up throughout the podcast. And finally, we're delighted to welcome Sheri Ling, who is a geriatrician and Deputy Chief Medical Officer for the Centers for Medicare and Medicaid. Sheri, welcome to the Jerry Pal Podcast.
Delighted to be here with you.
It's a huge honor to have you here, Sheri. Before we jump into the topic of the podcast, which is going to be the age-friendly hospital measure, we have a song request. Who has the song request? Is it Stephanie?
I do. We are going to play Riptide.
And why?
Why Riptide?
I don't know. It's just a catchy song. I really like it. It's something that I'm always like humming and singing to myself.
And Alex has his guitar. Stephanie, you have is that a fiddle?
It's a violin.
Violin.
Fiddle can be either.
Fiddle, violin. And I forgot my cowbell.
That's okay.
Thankfully,
Yes.
Eric forgot his cowbell.
We hit it.
That's what we need. This is to turn into like a Saturday Night Live episode. Okay.
That was awesome. I think our listeners are going to agree that was amazing, but I was missing something.
What?
A little cowbell.
I thought you were going to say singing.
Just a touch of cowbell. Maybe in the
Great,
outro,
Stephanie.
I can
Thank
find.
you. That's so
Of
fun.
course.
I'm so glad we get to do some live music with not just me. It was great. Thank you, Stephanie.
Of course.
Okay, so we have done a podcast on age-friendly healthcare systems back in 2000. I think Julia and Stephanie, you were on for that podcast.
We were.
Remind me, what is an age-friendly healthcare system?
So the way that I think about age-friendly health systems is that, a lot of medical care is very disease-centric. And when you build an age-friendly health system, you can focus on all the other things that are very important, especially for older adults. There's a lot of other aspects of people's lives that should go into medical decision making. And so there's a framework called the 4Ms that we use for the age-friendly health system.
And remind our listener what the 4Ms are.
So they are what matters, mobility, mentation, and safe medication use.
My last question on that. If 4Ms or 5Ms?
Yeah, I had the same question. Sometimes, isn't there a fifth M? And what is that M?
So yeah, through the IHI and Hartford Foundation, we actually have the 4Ms. But I know some people add that fifth M, multi-complexity.
Yeah. I think in our last podcast, we were adding other ones like muffins and other M's. I'd encourage all of our listeners to listen to our last podcast on age-friendly healthcare systems, because I think it really does a good job to summarize kind of where we are and what we're doing with that. I am now going to turn to where we are now, and as we talk about now, the present and the future. Sheri, there is this new thing that CMS is it new? Has it been rolled out? It's called the Age-Friendly Hospital Measure?
Yes, it is. It is not really new. And you may be wondering, why this, why now? And I will say that the measure itself, the timing of the measure, really has depended on the evolution of the evidence and the readiness of the health system writ large, thanks to all of you who have been working hard at making and building age-friendly care even before we thought of the measure. And the measure also, really reflects these interacting, interdigitating concepts or domains that really translate to the opportunities to deliver care that better meets the needs of older adults, whether 4 or 5Ms. Really, it's about putting the person who needs care at the center. So really, the timing is built on the work that you all have been doing. But it's not new. It is something that has been proposed and finalized in play 2025. So
yeah.
And we're all submitting our first attestation this year, so in May. So we've been preparing for a while to do this.
Yes.
Yeah.
Attestation. Tell us more. What are you attesting to, and who's attesting?
Yeah. So the question about attestation is, many of the quality measures people are accustomed to have, specified data sources where information about who's in the numerator statement, the population at risk in the denominator statement, and reflects a evolution of the state of readiness of the systems for a quality measure. So the attestation is really reliant on the reporter that is, the facility who has an opportunity to say, oh, we deliver care that is consistent with the domains of age-friendly and all of the requirements. It's kind of like an all or none thing, reliant upon that attestation. Now, you may wonder, why is it? Why attestation? Why not just a fully baked quality measure? So the attestation is a means for us to have said, we believe this is important in the care and keeping of the people who we serve. We want to send a signal that this is important and also create the opportunity for systems to develop the processes, the care processes, and the infrastructure needed to fulfill all of the domains, but maybe do so differently. Some might start with what matters. Others might start with mobility. There's no one right answer. The right answer depends on, where people are in the evolution of care towards age-friendly.
So, Julie, it sounds like the CMS is asking institutions, hospitals in this case, to say, attest that they have done this, but it's not giving instruction about how they go about measuring these different domains. Is that right? And what are your thoughts about this?
Yeah, it's a bit of a middle ground. And I think, on the one hand, we're used to in healthcare, like very prescribed protocols that say like exactly how to deliver types of care. This is not that, but it's also not like totally greenfield, like there is, I'd say, a fair degree of prescriptiveness. And so just to give an example, if we think about the what matters domain, it says that you need to have a conversation around a goal of care at like certain moments in a care journey, admission, discharge, when there's a major change in clinical status. So it is prescriptive. It's not sort of wide open, but there's also a lot that could be interpretive, like what counts as a major change in clinical status. Reasonable people, I'd say, would probably come to different conclusions about that. So I think it's a really great place to start for our country where like it is prescriptive and it is evidence-based, but there's still a lot we need to learn about how to turn it into something that I would call like a really tightly prescribed care protocol.
Well, can I ask you this, Julia? Like if you had a magic wand, if you were Sheri, like would you do that? Is that what you see in like 5 years from now that you would be advocating for? More prescriptive? Or we're just still in the learning phase to figure this out?
I think we're still in the learning phase. I mean, you asked a researcher that question. And so my answer is, of course, going to be it's something we need to study because I don't think we know which are going to be the pieces that are really critical to contribute to improved outcomes for older adults. And so that's our North Star here. And this is going to be an opportunity for massive experimentation because all hospitals are going to probably approach this a bit differently. And so that will allow us to really understand what is the best approach. And within that, I think the key is how do you deliver the 4 M's or 5 domains as a set?
Yeah.
Because you can do each one and sort of optimize how do you have a good conversation about what matters or how do you safely prescribe meds. But where I hope we'll really focus that learning is how do you bring all the pieces together? How do you have a goals of care conversation that then informs how you prescribe, how you set a mobility plan? It's really bringing all of them together that I think is the holy grail here.
And I do appreciate a lot of leeway here at the beginning because every hospital system is so different. And there's a lot to work out, which discipline is going to do this screening and this action. And, I think that all has to be kind of negotiated and figured out. And we have to all sort of work together as an interdisciplinary team in the hospital. And I think every hospital is very different based on the resources that they have, et cetera. And so, I think it's nice in the beginning to give us some leeway, but I know Julia and I have talked about before, we do want to get to a place where we can compare places, different hospitals and sort of understand, are we improving outcomes with all of this?
And do you think as far as, that point about outcomes, so we've been thinking about this as well. So what would be the outcomes that would serve as our measuring stick?
Yeah.
Right. And that's part of the challenge of the current health system where, care proceeds whether or not an individual patient's goals are even known or documented or what their preferences are. So, I wonder how do you think about that, from where you sit at the points of care, and also how should we be thinking about that?
And maybe we can break that up for each of these like 5 domains. Would that be reasonable? What do you think, Julia?
I mean, I guess I might lean the other. I mean, I think it's like the key question that we have to ask at this moment.
Yeah.
And in some ways, I think, if we do break it down by domain, again, we've like lost some of the purpose of like practicing these together in a way that improves like the big things that matter. And so I would say like, let's not pick one outcome, but let's pick a set of outcomes that collectively represent the things that are important to older adults. So patient experience of care, time alive and out of the hospital, frailty and functional status. So I think we're going to want to sort of pull together a set of outcomes that sort of collectively represent the domains that we would say that age-friendly care is striving towards.
Yeah, and I think we have different stakeholders too. I mean, obviously the most important is the patient and the caregiver and outcomes for them. But also myself as an implementer, I have to think about sustainability. And so finances are something that I need to prove to a health system in order to sustain all this work. It costs money. So, there's different outcomes for different people. And I know we have to have a few of them in every domain.
Well, let me ask you this. Is there a carrot or a stick for this CMS outcome measure?
Oh, that's a great question as to, what is ready for which type of incentives, right? Rewards or negative adjustments. it really all is going to depend on the state of readiness and the type of comments that we receive, because we're starting here with the inpatient quality reporting system, right? Which is pay for reporting. And the evolution could be towards hospital value-based purchasing. After hospitals get accustomed to reporting with the attestation-based measure for public reporting and pay for reporting, but no other positive or negative incentives are applied. So we're thinking about, like, when's the right time to move this further?
Yeah.
And also, is this the right way to move this forward? Could we think about specific elements of one of the 5 domains, or, the most important of the domains, and think about spreading this across different care settings? So no one right answer, just illustrating how one might think about this.
And to be clear for our listeners, at the time of rollout, which is coming soon, there are penalties, I believe, right, for hospitals or systems that don't attest. Is that right?
Not the first year.
Not the first year.
Yeah.
Okay.
We have some time to get this together, but probably eventually, maybe next year. We'll see.
To be totally precise, you have to report, but you could report all no's, right, to get full credit. So there's not a requirement of actually saying that you're delivering age-friendly care in this first wave, but you do have to report. And I think that's really exciting, because we'll have our first national baseline of what hospitals across the country are doing with respect to these age-friendly care processes. And then I imagine from a CMS perspective, it then allows you to make some of the decisions about how quickly you can ramp up, because we'll have that national baseline.
Okay, so at this outset, there is no penalty for not doing the attestation.
Well, you want to complete the attestation, but you don't need all yeses yet.
Okay, you want to complete it, but still, there is no penalty at the outset when this starts.
I should probably confirm that with Sheri.
Or reward.
Sheri, is there?
This is the run-in period, if you will, right, where we are trying to get people to just participate. And, there's always a score. Now, this measure, it's specifically, because it's attestation, it's all or none. So the information hopefully will be useful to those who are actually submitting the data, which is really, what quality reporting is. Because it's not just to satisfy CMS needs, but it's really to be able to improve at the points of care.
But I would like to say, so I've been working on age-friendly health systems for about 8 years, and I feel like I am nowhere near really good quality care for every single older adult that enters our hospitals. And so it will be interesting to sort of see how long, because there's actually a lot more requirements in the IQR measure than there are in the age-friendly.
IQR?
IQR? What's that?
That's the Inpatient Quality Reporting Program.
Okay.
This is one of several measures, not all of which, so some of which are used for the STARS calculations, which, that is how you find top-line facilities. But, it's a possibility that this measure, or a measure like it in the next iteration over time, can actually also get there. Right? But we want to follow the state of the evidence, the state of the readiness, and really, keep in mind that one of the domains is having leadership, right? Age-friendly leadership. And so not being prescriptive about that was inserted as an opportunity for facilities to identify their own talent that can get them to the goal of providing age-friendly care.
Maybe I can ask, since we keep on bringing up the components of this measure, maybe we can just briefly talk about each component. And, is it the same as the 4 M's? Is it different? Stephanie, Julia?
Do you want to start with one in particular?
Let's start off with eliciting patient goals. That seems like what matters. That's a 4M right there, right?
Yeah, it's slightly different than what we had been doing in the regular age-friendly health system, which, initially in the age-friendly health system work, doing advanced care planning and asking for surrogate decision makers was different than asking someone what matters to them. However, in these new hospital measures, there are components of getting, advanced care planning, different tasks done, like surrogate decision makers and things like that. So it's slightly different. Yeah.
So the question I'm dying to ask is like, what do you worry about? What's the worst case scenario? And what are you hoping for? What's the best case scenario? And so I worry about, the Patient Self-Determination Act, which mandates that every patient who's admitted to a facility is given an opportunity to complete an advance directive, asks if they've already complete one, they're given an advance directive. And it just like,
but
so
we can check
all
it
the
off,
evidence
right?
to date
It happens.
suggests it hasn't really done much. Is there a concern that this approach is mirroring that, and to what extent does it go beyond that?
I personally have concerns because I think there's a couple, like if we're following every little rule in the hospital measure, there's actually like 5 things. Living will is one of the things in there. And so that is just not very reasonable during a hospitalization to complete. And so, yeah, I think there's opportunity. What's great, though, is CMS is taking a lot of our feedback. I send Sheri emails all the time and, a paper that Julia and I wrote so that as I'm trying to do this, I'm realizing what's working and what's not working. So I know that they're listening, and what exists right now will probably not look like this, in years. If you think so too, Sheri, that's sort of my understanding as well.
Yes. And what we're hoping that this will evolve to be more meaningful quality reporting, right? And so, the attestation-based measure is one start. That can also be formulated as a structural measure or as a quality measure. In the meantime, though, we started to hear the importance of, these goals of care conversations. So have introduced the concept of advanced care planning with a variety of iterations, including identifying healthcare agents, right? Or a healthcare agent. And so of note, part of the quality measurement proposal process is that CMS has to take the measures that we're thinking about or considering on the measures under consideration list. It's a terrible acronym. It's the MUC list. But nonetheless, we take it to a consensus-based entity for conversation, discussion, deliberation. Is this a good idea? Is there room to improve? Is the value or potential value of a measure, does it outweigh the burden of the reporting? And so we took the advanced care planning measure not only for acute hospitals, but also said, well, what about other care settings?
Yeah.
To the consensus-based entity. And there was a lot of support. In fact, more support than concern. So that gives us and CMS the ability to propose in rulemaking an additional measure for the inpatient setting, and also to consider what should it look like in post-acute in other care settings, which is, I think, evolution in a different way.
Yeah.
So IQR, the attestation-based measure, still stands, but we're trying to push the system to move beyond the checkbox. And I think that's really important. And some of the details which CMS may never be able to see, but, it's how does it happen at the point of care? And, we have to take our own personal experiences of what it was like at the point of care for us. And, no secret, one of the things that keeps me motivated is so that others who may not be as aware of how things should roll in the hospital may not have the opportunity to really, raise questions and say, oh, isn't there someone else I can speak to other than the unit secretary about what my goals of care are?
Yeah.
Which that fulfills the checkbox, but so much more needs to happen. So long answer to your question.
Thank you.
And for each of these domains, like what matters, there are subdomains that you have to fill. I heard
Yes.
living well. How far does it go down? How many subdomains? Are there subdomains of the subdomains?
There's just subdomains of the domains. Some domains have more subdomains.
Like big picture, like for what matters? Do you have a sense?
I mean, I think there's like 5 things that I need to check off, but I think what makes it hard, and Julia and I talk about this all the time, is that these conversations have to happen at admission, discharge, and when there is a change in clinical status. And so I'm working with Julia, and I'd love your thoughts to think about how we measure this. I mean, what matters is very hard to measure in itself, but these sorts of things are also, how do you measure from an EHR if I wanted to prove to CMS that I'm completing
because it's hidden
this?
in most EHRs. It's in some note. Is there some advocacy?
Well, even a change in clinical status, how would you even mark that point of time so that I can prove to CMS that I'm hitting that measure?
An ICU admission is probably a good, I don't know. Julia, what do you think?
Yeah.
So, I mean, this is a really great question because, this is also about the state of readiness of the depth of the information that's required. And ultimately, the question will be, what will be helpful to track for the care and keeping and decision-making of the patients. So I think we're taking that, at face value and saying, let's be flexible here. We want the information reported, but really that information is also meant as a mirror of what is care like? How is the documentation rolling? And what we are also learning is that where it's documented could matter, right? If you're actually trying to vacuum up information from your EHR and all of the good stuff is in the social worker's notes, which for me, it always is, but maybe that's not where people are looking for the measure construct.
Yeah.
I mean, that's important for us to know too. So we're going to learn from the implementation on these measures.
Yeah. What do you think about that, Julia?
So, I mean, I think what we're seeing, which is the most exciting part, is that hospitals are coming to the table around this in a new way because everyone is trying to figure this out and they don't want to do it in a vacuum. And so there are new groups, Vizient as an example, that's now stood up, a working group around age-friendly. So I think we're just seeing a real broadening, they're the diehards like Stephanie who have been at this for 8 years. But the whole point to my mind of doing this at the national level is to bring everyone else into the conversation. And so I think we're really seeing that happening. And then
do you think it makes it easier to advocate for what you should be doing and for really true age-friendly healthcare systems?
Absolutely. I think even for the diehards, it allows them to go back to their hospital leaders and say, oh, now this isn't a CMS measure. So this is not a nice to have, this is a must have. And so we keep hearing this is a revitalization moment.
Oh, that's great.
For age friendly.
Okay. So we talked about one, which is eliciting patient goals. Number 2 is medication management, right? That's a domain.
Correct.
And I'm wondering here, because I don't know, we're forced to do med rec here, and it feels very performative in our current system. But how do we think about medication management? Because this is not just med rec. This is Beers criteria, high risk medicines. Is that right?
Yeah. So you want to, the actual measure is asking you to review if the patient's on any high risk medications and consider them for, alternatives or discontinuation or tapering, et cetera. Again, it's a pretty vague thing, which is great. And I think every place is doing it differently. But some of the questions that we've sort of had in the research space is, is this every single Beers criteria med? Because there's tons of hypertension meds, et cetera, on there. Or can we select the highest risk ones? And so Julia and her research team are trying to work with a lot of these other health systems to sort of think through what should be the standard here.
That is terrific to hear, really, because, as we're thinking about, the construct and the requirements for this measure, for future measures, what we're hoping is that it creates opportunities for the experts to actually inform what the local policy, the local decisions, and Eric, to your point, to be able to ask for resources that are necessary, right? So that you can succeed, and success is not, a plus or a minus on the dashboard of the quality report, it's success or not, it should be like, are your patients actually doing better?
Yeah.
And are we delivering to better health outcomes?
Is this
So-
changing care plans and not just documenting
Exactly.
that we're giving bad
Yes.
meds, but we're actually doing
Yeah,
something?
we found that our highest
Yes.
flagging med is gabapentin. So,
Ah,
Boom, boom,
surprise
boom.
there. Okay.
yeah.
Stephanie Rogers did a wonderful Instagram post on gabapentin. Check out her Instagram. That's the
Yeah.
second plug I did for that.
Thank you.
Okay, so we got listening patient goals, medication management, which is not just med rec, frailty screening. This is when we're thinking about M's, mobility, I'm guessing, like aligns with mobility, potentially also mentation, like they're all interconnected. I think for most clinicians, their idea of frailty screening is eyeballing a patient and saying they're frail, they're not. Is
Mhm.
that what we're talking about, frailty screening, or what are you doing at UCSF, Stephanie?
Yeah, I mean, I think people think of this differently. So, I started in the age-friendly work before this measure came apart, where there is a screen and act on for everything that you do. So we do a daily mobility screen in the morning, which actually sets a mobility goal for the patient for the day. And then we can determine whether or not that mobility goal has been achieved. But every health system is doing this differently. And this is where the two things sort of don't align, because the Medicare one doesn't have that act on. Well, I guess it's sort of vague about the act on component. Like, I think it's important to, know what someone's mobility is, but also make sure that they're working to the highest of their functional ability and sort of tracking that. So there's a lot of leeway, and I think how Medicare is defining this. But again, I think we'll learn over time, because people are doing this very different ways.
Julie, I got a question for you. What do you think about the frailty screen domain? Again, there's one thing to screen for frailty, but then a lot of clinicians also will think like, what do I do if they screen for frailty in a hospital setting?
Yeah, I mean, absolutely. I think we have to make these actionable, and there has to be a next step built in. And I think, again, partly because I come from the technology world, I'm like, this is where a technology's opportunity to shine is.
Yeah.
And so we should be able to sort of connect assessments to next steps. Again, build that into the electronic health record so it's a clear workflow from start to finish.
Yeah.
And we've had several podcasts about frailty. We had the creators of eFrailty on talk about all the various different ways in which you can measure frailty. We had Linda Fried on to talk about the Fried approach. I assume you're using more of the like Rockwood type accumulation of deficits, like looking at the EHR to see like, do they have a history of this, that, and the other comorbidity and sensory impairment, mobility, etc. Is that right?
Well, it's actually a frailty screen is not in that domain. I think it's just sort of the gestalt of the domain, but in that domain is actually mentation screening and a couple other things. So it's things that maybe affect people's frailty, but there isn't an official frailty screen in
I
there,
was
which
wondering what
I'm
was going
happy
to happen
about.
to the 4 M's, because mentation didn't look like it was one of the big
Yeah,
domains.
it's actually
but
in the
part-
frailty domain.
It's in there.
Oh, so it was folded into there.
Mm-hmm.
Sheri, any
Right or wrong? Yeah.
history about how that came to be that you could share with our listeners?
Sure. So, I mean, there's a lot of conversation about like, what is the right frailty screen tool? And this is an opportunity to pick something that works for you. And to the points made earlier, build some action around it. Like, what does it mean? It should be helpful for the care team, right? Who's doing wherever they are in the system. And in this case, it's in the inpatient setting. But one of the challenges is, and this also speaks to like why we're trying not to be prescriptive, is same patient, same conditions, then transitions to post-acute care. And how do we think about that? And, more important is where are people starting? Where are they ending during the course of a stay and at the point of transition to the next location, and to be able to use the information in ways that help them.
Yeah.
So trying very hard not to be prescriptive. And on a side note, in the maintenance of certification, had the opportunity to answer the question, which was, which of the following, you're a consultant in a clinic now, and you can choose one of the following in 5 minutes or less that could be done. Which would you choose? The right answer was walking speed. And I was like, that's pretty cool that we actually, and so
it made a difference.
Hey, maintenance of
Gate
certification.
Nice.
Yeah, it's working. We're learning from it. Yeah, Julia.
Yes,
Real
exactly.
quick on domain 3, too, because I think one of the really amazing things about this measure is that it's actually started to really push towards thinking about transitions into the hospital and transitions out of the hospital. And so part of domain 3 is actually about ED boarding time and activities to reduce delirium. And the same thing in some of the domains we've already talked about. It's about how do you continue that care in the post-acute setting. And so I think it's like really one of the things that doesn't get talked about enough in this measure and that I really want to highlight, because we don't want to deliver age-friendly care setting by setting. Yeah. We want age-friendly care across the continuum. And I think this measure is like a really strong signal of like the importance of moving towards that. And so again, just didn't want to lose that as we're talking about each of the domains.
Thank you. Yeah, super important.
Part of the requirement is that you have to report the mentation and the mobility baselines, all of that on discharge to the next setting. So
wow, that's great.
Really, yes, that's very important. So I'm glad that's in there.
That is wonderful. So we get a better sense also of hospital-associated disability that happens. Mm-hmm. Okay, I want to talk about the last two real quick because they feel a little different than the 4Ms. Social determinants of health. This is an interesting one because like we can identify social needs, but hospitals aren't really social service agencies. Well, maybe. I don't know. What do you think about that?
This one we're really struggling with because we're struggling with who owns this sort of screening. And then when we uncover these things, which are usually very big, who takes on those tasks?
With an average hospital stay of probably 2 to 3 days?
Right.
Like, can you fix social determinants of health?
Yes. But there's good things in there that we often forget, which is, caregiver fatigue, things like that. So it is sort of having us standardize those types of screens. But then I think the hard part is trying to know what the action is.
Yeah, also call back to a prior episode with Kirsten Bibbins-Domingo, who wrote about the need for health systems and clinicians to address and capture social determinants of health. She's now the editor at JAMA. Eric, you have a question?
Yeah, Sheri, how did this one come up? If you're able to share, kind of this is probably the most fascinating one for me.
It is, and it tests the limits of like CMS authority. It tests the appropriateness of attribution and capability to take action on what you learn and what you find. We thought it would be an important element that may determine people's outcomes, regardless of what the disease is or what but it does align very well in that interaction with the state of the human being and the context of where they are, what their factors are. So, it was a first pass actually at really expanding the aperture on the limits of your impact, right? Yeah. And we actually went there also in a prior iteration on smoking cessation, and tried to think about, where does everybody go? They all go to the hospital, and the hospital's like, yes, but that's not our job to make people quit smoking. So this is a chance actually to really explore with the community. How do you synthesize and continue care even beyond what happens in the acute hospital? Let's pretend they don't go to post-acute care, but they go immediately home. So this is one that we also are going to learn a lot about how the systems are functioning.
Julia, real quick, any thoughts from you on this measure or domain?
I have heard people talk about as caregiver stress. I think everyone is stressed about caregiver stress because again, it's like from whose perspective, what do we do about it? And so again, it's like everyone knows this is critical, but I have to say that is the one part of the whole measure that I probably heard the most chatter about because people really feel like they don't know what the right thing to do there is.
Okay, I got to ask about the last domain because this one's interesting too, leadership and governance.
Thank goodness it helps me keep my job.
What is this one?
I mean, it just is basically that each hospital has to designate leaders of, the age-friendly health system work, which is great. At UCSF, we have a nurse leader and we have myself. And so I think, again, it's helping because you need people to sort of lead this work. So I think it's really helpful.
Do they have need any expertise in geriatrics or aging or gerontology? Or
Well, from what we've heard from many different health systems, there's all kinds of people that are taking these roles. And of course, everybody who is taking these roles believes in what they're doing, but they're not, there's very few of us geriatricians.
And there's no requirement that it be a geriatrician.
No.
Not at this time.
That'd be impossible.
That'd be impossible because there aren't enough geriatricians to fill these
Nothing's
roles.
impossible. Stuff.
Well, that's true. We'll think big.
Right.
Always think big.
Is that what CMS was thinking when they put this? Is that we want, you need to have like that, not just the stakeholders involved, but somebody leading the initiative?
We need leaders, right? Leaders who actually are engaged in care and know how hard it is, and also engaged in evidence generation and taking up that evidence and putting it into play in patient care and policy. And so, one thing that we have observed over time is, and this is well known. I mean, we're really good at acute care, right? In the care delivery, acute care, but we have the burden that our population actually endures in chronic illness and the complexities thereof.
Yeah.
It's not a great fit.
No.
So I think the need for leadership is pretty clear. And also, how to improve upon the current state.
Yeah.
So really converging age-friendly with, quality improvement in the context of care delivery, I think is really a need and an opportunity going forward. And yes, we need more folks to understand this entire ecosystem. So we would be delighted if more people wanted to join us at CMS and even taking on fellowship projects that work on and focus on policy and translation.
So I'm going to go to lightning round question because we just have a couple more minutes. First, any of you, if people are interested in learning more about this measure, where should they go? Is there like repository places that they can learn more about the measure and how to, institute in their hospital?
Two different questions, right? Maybe three different questions.
Okay.
So the measure details are published on the CMS website. Taking that into account, though, the how to implement, best place is starting within your own system, looking for your leadership who actually can take the opportunity to say, hey, here's what the broad strokes of what is expected, but here are our suggestions of how to get there, right? Go to the experts. The experts are on this call and elsewhere.
Yeah. And Stephanie, how would you answer that question? What are you using as resources to do this implementation? Obviously, CMS website.
Yeah, and the quality department now has to take this on at our institution, so I work with them. Yeah.
And Julia, any other resources that would be helpful?
The communities of practice that are coming up around this. Again, some of them are at the Institute for Healthcare Improvement, Vizient, the Pepper Centers are now at the table doing a survey of how hospitals are operationalizing this. So I'd say go to your community of practice too and ask, who's sort of organizing.
IHI, Hartford Foundation has some stuff too, right? On this. So we'll have links to that in our show notes. Last question for me, then we'll get to the song. Lightning round. In 5 years from now, do you expect care for the older adults who are hospitalized to look different because of what you're doing today? And if not, what do you think needs to change? Again, maybe 2 questions there. Stephanie.
I think it'll look different, but I still think it's going to take us a long time to do all of these things very well for all the older adults, which are about 50% of all hospital populations right now.
Wonderful. Julia.
I'm going to go with a yes. I think we're going to pay a lot more attention to the different dimensions within age-friendly care, and we'll have a lot better documentation of sort of screening, but it gets to that actionability piece. And so I think that's where we're going to really have to focus if we want to have impact on outcomes.
All right, Sheri, you're last before the fiddle/violin comes into play.
I will actually also go with yes. I am the eternal optimist, but I will say it will take all of us to get there.
Yeah.
So just thank you for all the work that you're doing and for the opportunity to be with you today.
All right, now a little bit more cowbell.
Yeah,
song.
We're just gonna do the chorus here.
I can do it.
Sheri, Stephanie, Julia, thank you for joining us on this podcast.
Thank
Thank
you.
you.
Been an honor. Thank you.
And to all of our listeners, thank you for your continued support. We'd also like to do a special shout out to all of those supporters who've donated more than $250, including
Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Emise Samoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Kari Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Young, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Xinyi Wang, Sudha Chandrasekhar, Michael Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky, and Yana Scharf, Kelly Strait, Michael Bordowski, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, John A. Hartford Foundation, and Harry Hahn.
thank you very much for your continued support over the last year. Your support keeps these lights on.